we'll get started. So Dr. Ayler made a nice introduction, so I'm familiar with everybody in the room. So I wanted to do this topic because I thought it to be very relevant, which we'll talk more about, and also interesting, and also personally something I needed to learn more about. So the CDC is an excellent resource, and that's the picture I have on the right. Their handbook on the tick-borne diseases of the U.S. is very comprehensive and also very easy to access online and an easy read. So that was my primary resource for my talk. So we'll get started. So the objectives for the next maybe 40 minutes or so are the following, and I hope to relay that to you guys. So I want us to understand the relevance of tick-borne diseases and its epidemiology, learn how to identify common ticks and their associated diseases, identify preventative and prophylactic measures, and then we'll review some 2018 Lyme updates, and then finish off with discussing kind of the future trend, climate change, and what role that plays. So over the last, even year or two, there's been more and more headlines on tick-borne diseases, and in pretty major news articles and journals. So, and the problem is that it's on an uptrend, an uprise. So the number of reported tick-borne diseases has been more than doubled over the last 13 years, and the public health burden of tick-borne pathogens is very much underestimated. So for example, the CDC reports that maybe about 30,000 cases of Lyme disease occur per year, but they estimate that the true incidence is about 10 times that number. And that's to various reasons, whether it be per reported clinical history, diagnostics. I think that they all play a role, but it's very much underestimated. So looking at, this is the MMWR report from May 2018. And they were looking at the reported vector-borne disease cases from 2004 to 2016. So, and it included about 16 nationally reportable diseases during this period. And so that includes, your Lyme disease, but also anaplasmosis, ehrlichiosis, babesiosis, all kind of fall into this. What was interesting is that the number, like I had said, it more than doubled, and those are your actual numbers that they reported, which is 22,000 to about 48 in 2016. And then Lyme disease, of course, was the predominant one, so it made up about 82% of the tick-borne diseases that was reported. And this kind of shows you numbers-wise. So I'm only showing you guys the last 3 years, so you see similar numbers when you look at the total. But keep in mind that that's, a decade later. So if you look back 10 years ago, that was about half, if not less than that. And then your Lyme disease, of course, make up most of that. So this is kind of a visual representation. So tick-borne disease, which account for about 75%, if not greater, of your vector-borne diseases occur throughout the continental U.S., but you see the shades of blue that are darker are, of course, where you expect there to be more predominant cases. So that's in your eastern part of the country, and then, of course, along some along the Pacific coast as well. So the darkest shades are where you have the biggest problems, and that's from 2016. So the next few slides, what I wanted to go through was highlight where the diseases play a big role. You're going to see a lot of overlap, but I think that's important to know when you're trying to figure out the most likely case in the patient that reports a tick bite. So the maps are all different colored, and then each dot represents one case. So this is comparing anaplasmosis and babesiosis, which kind of the babesiosis is more so in the eastern area, but you see that anaplasmosis can also involve your Minnesota, Wisconsin region. And then Lyme disease, of course, is very, very much dense, and that's in the same area, but if you see ehrlichiosis, it's kind of spreads more down south near Missouri, Arkansas, in that region. And then your rickettsiosis, again, it's more in the southern to mid-east area instead of northeast. And then tularemia is very sparse, of course, but those are the regions that you would expect to see that. So before I go into, the various ticks and their associated diseases, I think it's important to know how ticks behave as vectors. So tick mobility is typically limited to its animal hosts. They rarely cause sudden epidemics. So humans are typically incidental hosts, and their prolonged life cycle and widely separated blood feeding limit the opportunities to cause pathogen transmission. So that's why we're not seeing huge epidemics. But, so for example, you see Ixodes scapularis, so that's your black-legged tick that carries Lyme, and that's what you see depicted there. It might feed on blood maybe once a year, but this is compensated by the fact that it has broad host preferences and ability of a single tick to transmit multiple things, multiple pathogens. And then of course, as we'll learn more about, that's your important vector for Borrelia burgdorferi. So I thought this was interesting. So how ticks find their host. So ticks are generally found near the ground, in brushy or wooded areas. They can't jump or fly. So instead they climb tall grasses or shrubs and then wait for a potential host to come up and brush against them. So when this happens, they climb onto the host and then they wander. They may attach immediately, but they can also wander around and find the ideal place for attachment. So that picture right there is actually how they wait. So that bottom couple pairs is them latching onto the whatever shrub or grass, and then the top couple pairs are waiting to attack or attach. And they also they interestingly detect animal breaths and odors, and even shadows at times. So heat, moisture, vibrations, they're all very much sensitive to that, to recognize their host. And then we kind of talked about the other points there. They prefer cool places, so sometimes they like to go near the ear, in like animals and pets, near the ear, in the folds, so popliteal fossa, like behind your knees. So those are all very much places to check. So this was in experimental and applied acarology in January 2019, so very recent. They were proposing that there may be a gender preference when it comes to tick attachments. So the study had male and female human volunteers, about 20 pairs. They breathed into opposite sides of this secured polycarbonate tubing, and that contained about 10 adult ticks, the AMERICANUM ticks, and the proportion of ticks that exhibited a host preference was recorded. And under controlled conditions, they saw that significantly more proportion of the ticks went towards females, sorry to say, than males. And their hypothesis, or things they were postulating, was either the female breath contained components that they found attractive versus males that was repellent. But there's more ongoing follow-up studies to look into this, but I thought that was interesting.
Was it an equal number of male and
Yes. Yes. Oh, yeah, male and female ticks? Or the female is usually the one that is a pathogen carrier. They're the ones that attack. So yeah, so females, yeah. But the human volunteers were even, of course. So how diseases spread? So typically, as we would predict, it's through feeding. Feeding's the primary way of transmission. And depending on the tick species and its stage of life, preparing to feed can take anywhere from 10 minutes to about a couple hours. So the tick grafts the skin, cuts into the surface, and it inserts a little feeding tube, and with like a cement-like substance to keep it attached so it doesn't easily come off. And then the saliva also has anesthetic properties, so you don't realize it's on you. So it's important to know that transmission can occur both ways. So the saliva the tick itself can obviously carry pathogens that's transmitted into our blood, and then vice versa. If the human host or whatever host has an infection, it goes into the tick, and that's how it transmits it to the next host. And this occurs with pretty much any host that it has. So the life cycle, and we discussed it briefly in the beginning of the lecture. So the life cycle has 4 stages. It has egg, 6-legged larva, and then you have the nymph stage, and you have your adult. And this is from CDC, nicely depicts the cycle. You have, typically in the springtime, that Dr. Taylor mentioned, is when the onset occurs, and the eggs become larvae, and they have small animals that they can attach on. You see birds and mice and rodents. And then the nymph stage is actually the biggest problem in Lyme disease. The nymph stage is actually the predominant stage where we're at risk for infection. After hatching from the eggs, the ticks must have blood at every stage to survive. So the ticks that require multiple hosts can take up to about a few years to complete their full life cycle. So a lot of the times they don't make it that far. Most will die because they don't find a host or for their next feeding. And like I had mentioned, the host can be a variety of things: mammals, birds, reptiles. Most prefer to have a different host at each stage, but we'll talk about some ticks that prefer the same host, like for example the brown dog tick. And then what's depicted here is the black-legged tick, so that's your Ixodes scapularis. So the 3 main ones I'm going to talk about, and I think for our purposes in the scope of this talk, we'll focus on the ones that most commonly cause disease in humans. So that's going to be your black-legged tick, your Lone Star tick, and the American dog tick. And then there's a couple I'll mention, but not kind of go too in depth about. So the black-legged tick, so that's the Ixodes scapularis. So learn to identify kind of by how it looks. So you have the black and the brown kind of 2 crescents, and it transmits the diseases listed there. So Borrelia, of course, and then anaplasmosis, Ehrlichia, Babesia, and Powassan. So this is kind of your major problem. And the Ixodes pacificus is in the western states. So that's the California region that was highlighted in the beginning where you see ticks. That plays a role there. And the map I just included there so you know where you expect to see this. And just for the talk, I'm going to list here the diseases, but not delve into kind of individually the clinical manifestations. So the black-legged tick, it's the greatest risk is spring, summer, and fall. It's in the eastern U.S., like I said, and then all stages bite humans, but remember the nymphs play a bigger role in Lyme disease. However, keep in mind that adult ticks may be out searching for a host at any time winter temperatures are above freezing. So just because it's winter doesn't mean you're completely risk-free. And I included this for size. That actually is a corner of a dime, just a bottom left, right corner, but it tells you, kind of gives you an idea of how big these ticks are, or how small I should say. They're very tiny. So then you have your Lone Star tick, and so that's the Amblyomma americanum, and that's very easy to identify based on that marking on its shell. It transmits ehrlichiosis, tularemia, and then Heartland virus, and then STARI as well. So you have overlap. This has ehrlichiosis as well. And it's key thing to know about this tick, it's very aggressive. So what I mean by that is normally ticks wait around, like I said, and wait for the host to come. But these actively seek out hosts. Like they're just waiting to have a blood meal. So all 3 stages, again, will feed on humans, and they readily feed on dogs and cats. So this is where pets become an issue. You have to really be careful. And it's similar distribution, but I would say it's more so in the southern states than where you would see like the Lyme population. And I don't know how many of you guys have heard of this, but I think that's an important connection to the Lone Star tick. There's been reports of red meat allergy associated with this tick bite. So the alpha-gal is found in red meats, and it's also associated with the tick. So these patients, they may not have symptoms until about 3 to 6 hours after the ingestion of the red meat, but they typically have the same kind of symptoms, sweating, rash, hives, all of that can occur, but it would be more delayed as opposed to like a food allergy where you'd expect it to be pretty immediate. The adopting red meat free diets certainly allowed for further anaphylaxis or issues, but the patient population that we're looking at, they followed up 18 months to 3 years, and definitely kind of keeping that out of their diet did help. Detailed history is key. So if they're coming in with these symptoms, then talking to them and seeing when exactly the tick issues occurred. It's unclear why some people are more prone to this than others. I tried finding evidence-based studies for that, but it has not been established. They estimate about 10% of the population in the U.S. have elevated IgE titers against this alpha-gal component. And then the last thing I wanted to talk about with Lone Star is kind of differentiate Lyme versus STARI, which is actually very difficult. Clinically, they have very much similar symptoms. This chart kind of just helps figure out if there are any discrepancies between the two. So the etiologic agent, of course, we know is Borrelia and Lyme disease, but STARI, it's not clear. We don't have an agent. And then the region, like I said, it's more southeast U.S. with STARI. The vectors listed there, and then we talked about the stage as well. Clinical presentation, they both have EM. Looking through kind of CDC's review of this, the STARI, you can have multiple lesions. They're smaller. They have more of a central clearing at times. These patients are more likely to recall the tick bite versus Lyme. I'm not sure if that's because Lone Star is more of an aggressive tick, but those are the kind of very faint differences that you see in history. But there's no link to chronic symptoms with STARI, and then you have of course, the neuro and cardio and late onset arthritis, all that with Lyme. So the American dog tick, which is dermacenter, it transmits tularemia, and then rickettsia, Rocky Mountain spotted fever, and it's found in areas with little or no tree cover. So that's maybe a little bit different from the other ticks we've talked about, and that's how you identify it. So instead of like a white spot on its back, it's more of a curve or a little crescent there. And then lastly, brown dog tick. It's found worldwide. I just included this on there. It's because I think things to know is the fact that it's a primary vector in the southwestern U.S. and along the U.S.-Mexico border, and it also transmits Rocky Mountain spotted fever. And then the dogs are the primary host for this tick in each of its life stages. So this is one of the ones that stays with one host. But I think more rarely can do humans and other mammals as well. This depicts the life cycle of this and kind of what I just talked about. So you have each stage, so the larva, nymph, and the adult stage, and each time they can either transmit to humans directly or more commonly via animals. And so moving on to kind of prevention, so the common advice is to use the EPA registered insect repellents as you would do for mosquitoes. So DEET, picaridin, and kind of similar chemicals, repellents would be definitely recommended for prevention. So after arriving on the skin, Ixodes scapularis, the Lyme disease, usually takes about 24 hours before feeding begins. So that's why we kind of get that in the history when we talk to the patient. And even if a tick is attached, remember that it must have taken a blood meal to transmit Lyme disease, and most of the time that occurs 36 hours or later after the tick's been attached. So you want to treat the clothing and the gear and products containing 0.5% permethrin, treat your pets, and then you want to use fine-tipped tweezers for removal. So that's depicted there. That's the kind of the size of the tick you would expect. And thoroughly clean the area after. A few words on prophylaxis. So generally, it's not recommended for prevention with the following exception. So, there's no antibiotic treatment that's recommended for anaplasmosis, babesiosis, etc. And even in Lyme disease, except when you're in a highly endemic area, and they follow the criteria listed there. So typically the dose you would give is a single dose of Doxy 200 to adults who are pregnant and to children older than 8 years. When you don't have Doxy contraindications, obviously, the attached tick can be identified as an Ixodes scapularis, and the time of attachment is 36 hours or greater. And then prophylaxis can be started within 72 hours of the tick removal. So I think that's just an important thing to keep in mind so you know what patient fits the picture. And then tularemia is recommended, the prophy is just recommended mainly in lab exposures. So the Doxy, again, 100 BIDs, the dosing here for 14 days. And ciprofloxacin is not FDA approved, but it is an option if you can't do Doxy in these patients. So just some highlights and updates. So it's been a while since the first guidelines, or the Lyme guidelines last came out, so in 2006. So we're anticipating the new ones to come in 2020 winter in CID. So in the meantime, when I was doing my review, I did come across updates that was listed in JAMA in 2018. So just main points we're going to discuss in the next few slides. So the first thing, they did mention Borrelia, Miyamotoi, and versus Lyme. So the latter is actually a member of the relapsing fever group. It can be misdiagnosed as Lyme disease due to false positive tests in your ELISA. So I think that's important to know. There are no diagnostic tests that have been approved for this. PCR testing has been proposed and antibody testing as well, if you have, suspicion, but like I said, it's very hard to diagnose due to overlap. Unlike Lyme, though, these patients do not have a rash, but they do have more systemic symptoms: fever, headache, sometimes just myalgias, fatigue, sweats, things like that. It's transmitted by the same tick species that, as Lyme. You can have also CBC derangement, so leukopenia, thrombocytopenia, and in these patients you give about 2 to 4 weeks of doxycycline, and so similar management, but amoxicillin and ceftriaxone have also been used and have been of positive response. So then for Lyme testing, I think that's a big part of Lyme disease. I think this, along with chronic Lyme disease, is kind of the biggest areas of, controversy or improvement, I should say. So I wanted to discuss what we're doing right now. So right now, we do a 2-tier testing for Lyme disease. So we have your first test, which is your ELISA testing, and if you have a positive or equivocal result, then you go to their symptoms. Has it been less than 30 days or greater than 30 days? That 30-day mark can tell you if you just do an IgG Western blot, so that's if they've had symptoms greater than 30, or do you do both IgM and IgG? So you don't want to do IgM if they have been having symptoms for a while. If that ELISA is negative, then you want to look at your diagnosis and look at other causes. Or if you're very strongly, still thinking about Lyme disease, then convalescent serum, where you would expect antibody titers to be high, would be recommended. So the recent proposal has been to change the second testing. Instead of a Western blot to another ELISA test, these are easier to perform, results would be available sooner, costs would be reduced, and it would kind of eliminate that subjective element of interpreting Western blots. The specificity is greater than 95% for either. However, I think the major limitation that we have right now is, and the main problem is testing patients with low probability, and that changing that second tier doesn't get around that. So I think that's what the debate's been about that. So, and this is kind of echoing what I had mentioned. So the common misconception is that poor sensitivity of antibody testing is major limitation, which is not the case. However, for extracutaneous manifestation of Lyme disease, the sensitivity is it's excellent. So it's 87 to 100%. And if you have early neurosymptoms, you typically want to repeat testing in a couple weeks to see if you have positive testing. The issues, like I said, lie with inappropriate testing, not testing the right population, and then interpreting it incorrectly as well. And just a side note, the Lyme arthritis, almost all patients with Lyme arthritis will have a positive IgG antibody. So you expect that when they present with those symptoms. And if you test them and if they don't have that, then you're looking at something else. So then some treatment updates. The pediatric population, they approved, AAP approved a less than 21-day course of doxy in children less than 8 years. So initially that 8-year mark was more significant, but now they're accepting that for younger than 8 years. And the doxy, when you would want to treat with that, would be for a high-risk tick bite, where you're very much concerned of Lyme disease, or Lyme meningitis, or co-infections such as anaplasmosis. But in other scenarios, if you just have EM and you want to treat that, amoxicillin and cefuroxime are as effective to treat. Additional data have reconfirmed, they looked at 182 patients with long-term kind of residual symptoms of Lyme disease despite being treated. Further antibiotic therapy does not provide any benefit at all in that situation. So the last segment I wanted to discuss was kind of future trends and the impact of climate change on tick-borne diseases. So when we look at the risk for human infection, there's three main factors that play a role. You have tick vector abundance, so how abundant do you have the vector, the prevalence of Borrelia in the ticks, and then the contact frequency between ticks and humans. Climate change, in some way or another, impacts every single one of these factors. So geographic and seasonal distributions of Lyme disease are pretty much driven by the life cycle of vector ticks. Apart from the short periods of time where they're feeding, so that's like less than 3 weeks of their entire life cycle, they mainly spend their life off of hosts in various landscapes, right? So you have your woodlands, grasslands, and that's where weather plays a part. So temperature, precipitation, humidity, all can affect their survival and host-seeking behavior. With global warming, increasing temperatures and the changes in seasonal patterns are expected to result in earlier tick activity. So that this picture actually does a nice job of showing you the life cycle, but also shows you the seasonal cycle. So that's the green, orange, and the blue that you're seeing. And the dashed arrows show that you're going to have an earlier onset, an earlier spring onset, and then perhaps a later fall as well, making the tick period longer. And then we also see effects, going up north. So this is kind of showing you the number of cases. This was taken from Canadian Community Disease in 2014. It was looking at the number of cases per year of tick-borne disease in 2012. I mean, as you can see, it very much has an uptrending and an uprise. It's emerging in central and eastern Canada, so it makes you think there's contiguous involvement from the northeastern U.S. It's spreading up north, and this is a visual representation of that. So the map shows you the reproductive value of ticks in North America. So for example, you have the shading, blue, light blue, and red. The numbers depicted with the colors there show you the predicted rate of population increase. So for example, if every parent had 4 offspring, the ratio would be 2. So what that's saying is that in A, B, and C are the time periods. C is 2041 to 2070, so this is looking far ahead. We expect there to be more involvement in Canada with the blue, and then you also expect the areas in the south, the reproductive rate to be drastically higher. Your ratio would be up to 15. That red would be 15. So although that it would still be blue in the Canadian region, my concern, I guess, and the general concern is that ticks will become an issue up there, and that will have public health implications as well. So I think the main take-home points I wanted to relay was the ticks can have a variety of hosts and harbor several types of bacteria. Identifying a tick can help narrow the differential, and gaps in diagnostics can delay appropriate management. I think there's more work to be done there. And prevention and appropriate use of prophylaxis is also a key component of care. And lastly, climate change will definitely play a role in distribution of tick-borne diseases and affect seasonal onset. I think in the incoming guidelines that we expect in 2020, I would hope that they talk more about STARI, differentiating STARI versus Lyme. What do we do if in an endemic if you are in an endemic area where you have both? How does that change your approach? And then maybe touch more on non-antimicrobial modalities for chronic Lyme disease and how to approach those patients. So those are all upcoming, hopefully. So this is just going back to my objectives, and which we covered throughout the talk here. And those are my references. And that's all I have.